there, welcome back to ParentingU. I'm Stephanie, and we're here with another episode helping you navigate this amazing journey we call parenting. And today's episode is all about cleft lip and palates. We welcome Dr. Lisa Morris and Dr. Laura Hetzler, who are both dual board certified otolaryngologists and facial plastic and reconstructive surgeons. Did I say it right?
Perfect.
I need both of you to say the otolaryng word for me so we know everybody gets it right.
Otolaryngology.
Otolaryngology. I did it. Well, thank you both for being here. You are both part of the Our Lady of the Lake Children's Health Cleft and Craniofacial team. And so today we really want to talk about what is cleft lip, palate, what are all the things that parents need to be prepared for, maybe if they're facing this diagnosis. So we really appreciate your time. Thank you for being here.
We're excited to be here. Thank you for having us.
Of course.
Thank you.
Well, so Dr. Morris, our listeners, first off, may not be familiar with what cleft lip is. Can you tell us a little bit about it and kind of what it brings to a baby's life?
So a cleft lip and palate, you can have a cleft lip with or without a cleft palate.
Okay.
Or you can have a cleft palate all by itself without a cleft lip.
Okay.
So there's varying degrees of it. It's something that happens in the womb. So while the mom's pregnant, happens very early in the pregnancy. We can get into a little bit more about how it happens, but
Sure.
but it's typically something that's not anything that's caused that you can put a finger on what caused this.
Sure.
And with that, it's where the face would naturally form and come together, and it just didn't come complete. It didn't complete its full development, and
Okay.
right in that area.
Okay.
And when you have a cleft lip, what will happen is the lip itself won't be together, and then the muscles of the lip won't be together, and sometimes it goes through the gum line as well, so you'll have a break where the teeth would be, and you'll actually have a connection up into the nose, and if it's including the whole palate, then it's also the same connection all the way through the palate.
Okay.
And while this may sound a little overwhelming in the beginning,
Yeah.
it's actually quite common. About 1 in 700 kids have this diagnosis
really?
throughout the country, and so it's something we're prepared for. It's what we do all the time. It's actually, once you're in this world, you'll find out there's a lot of people that actually are around me that have the same thing. We just don't recognize it. We don't see it because most kids are having their lip repaired early in their life. And so it's before you're out and about. And our goal when we talk about the reconstruction of both the lip and the palate and the gum line is to make it so all that's left once it's repaired is just a thin little fine scar. And really should have no other impact on their life other than having a little scar on their lip.
So when you say cleft lip or cleft palate, that means the front, the lips, and then the roof of the mouth, right?
Correct. Yes. So the cleft lip is everything from the nose down to the opening to your actual lip itself.
Okay.
And if it goes through the gum line, that's also called the alveolus. And so that's a cleft an alveolar cleft, but a gum line cleft. And then it goes into the palate, which is the roof of your mouth. And your palate actually has two different parts to it. You have the part that you can touch right now with the tip of your tongue. That's your hard palate. It's really hard and it's bone. Yeah. And if you were to walk off the back edge of that, you're going to go into what's called your soft palate, and that's the muscle. That's the muscle that helps us with speech and with our ears and that aspect.
Got it.
And so it's all the roof of the mouth, and it ends back at the uvula, which is the hanging down thing in the back of your mouth. What's kind of fun for children with a cleft palate is that uvula actually splits into two. And so you have a little uvula on each side, and when we repair it, we put the uvula back together in the middle.
I didn't realize how common it was, so that's really good to know. And so when do you typically find out a diagnosis like this during the pregnancy?
So oftentimes it is discovered on their ultrasound, their anatomy ultrasound. Typically,
Okay.
some obstetricians do it earlier, some do it closer to 16, 17 weeks, but typically they find out around 20 weeks, certainly in the second trimester.
Yeah.
We do have some moms find out later because, fetuses, little babies don't often cooperate in the womb and they like to cover it. And so we normally find out around 20 weeks. At that point, typically the obstetrician or the maternal fetal medicine will refer them to us because we want to meet mom before the baby's born. We feel like talking with the parents, arming them with knowledge before the baby is born, I think is comforting to them, but then also they're not hearing it for the first time once they have a screaming baby in their arms. And so we meet with the parents, typically prenatally. We like to do it together. We also include our Cleft team feeding specialist to talk about the nuances and the differences in feeding a baby with a cleft. And the good news is that babies want to eat and they know how to eat, even if they have a cleft lip and a cleft palate. And so what they figure it out better than we can. And so we just give the mom the instructions, the typical type of bottles. We give them our cell phones. They have a way to contact us and our Cleft team coordinators, our nurses, our speech therapists. Not all of our babies come from the Baton Rouge area, so we can't see them right after birth. Sometimes we FaceTime, especially our mamas in Lake Charles or up in Monroe. We have some cleft babies from Mississippi. We have some cleft babies a little bit closer to along the Gulf Coast that travel to see us. And so we'll FaceTime with them, we'll look at everything and just try to bring them to ease.
Well, it sounds like it's really a team approach and a multidisciplinary approach. So tell me a little bit more about the Cleft and Craniofacial team. Who's a part of that and who makes up that core group that's really there to help the baby and the mom and partner dad along this journey?
So something that's unique to cleft lip and palate or families or individuals that have a cleft lip and palate, it happens when they're in the womb, but it's going to affect their growth throughout their entire childhood while they're going through their growth phases. And so we actually will follow them not only prenatally, so right before the baby's even born, and follow them almost all the way through adulthood or to adulthood, and sometimes up into the 30s or even further if need be. And so in that regard, we're ready to watch them through every phase of growth and be able to intervene and guide families and help along the way. And so with that, we need a whole team. And because it's of the face and because it affects structures that also link to other structures and other functions of our face and our anatomy. We have both myself and Dr. Hetzler, so as the facial plastic and reconstructive surgeons, to do a lot of the lip repair and the palate repair and a lot of the repairs, the surgical repairs that you're going to have. We also have a speech-language pathologist who starts right at the very beginning from the feeding aspect. But anybody who has even just abnormalities in the front of their mouth can have issues with their speech. But more importantly, when you have a cleft palate involved, it's our palate's main role is for speech. That is what we have a palate for primarily, is to help us with speech. Once we've repaired the cleft palate, we have to basically make sure that it's working appropriately. They're going to need therapy. They're going to need guidance to make sure it's working the way it needs to work. And so they're going to be in speech therapy in the beginning. And my goal is to make them be, the best speaker in the class is the whole point. And so there's no reason not to. So we jump on speech therapy from the get-go. And so we have plastic surgery, we have speech therapy. It will also affect the ears. So our palate muscle is what opens and closes our eustachian tubes, which is part of the anatomy of our ears that help us to hear appropriately. And so because the palate doesn't come together, the eustachian tubes can't open and close on their own until we repair the palate. And so in that regards, they're going to have some fluid in their ears. And so when there's fluid in the ears, it blocks your ability to hear. Not that you're deaf, but more the fact, like if you put your fingers in your ear canals, you can't hear as well. You take them out, you can hear normally. That's what fluid in your ears will do, the same thing. And so often they're going to need ear tubes. So we're also otolaryngologists, so we'll help with the ear tube placement. But we have an audiologist who is the hearing specialist, and so they're going to be monitoring their hearing and making sure they're hearing just fine. And we have dentists and orthodontists, because if the cleft goes through the gum line, it can affect the teeth that are in there. When we're born with all of our teeth for our whole life. And so if the cleft goes through that, sometimes it can affect the tooth buds and the developing teeth that are going to happen, that are going to be erupting into the mouth eventually. And so we have our dentist that helps with that, and they're pedodontists, so they're dentists who have trained specifically in pediatric dentistry and are very well knowledgeable and comfortable when caring with kids with clefts. And we have our orthodontists who will undoubtedly come into play for anybody with a cleft that goes through the gum line and into the palate region, because it will affect the shape of the upper jaw. And so we have to get all of that into alignment and plan for that in the future. And so we'll follow along with them all the way up into teenage years and into that adulthood years. So moving on, other people we'll have a geneticist that's part of our team to talk with parents about, how did this happen? And while we said most children that have a cleft lip or palate, it is nothing that you can put a finger on and say it's genetic or it was environmental or there's any issue that caused this. But every now and then you can have some that are syndromic or can be part of a spectrum. And that's what our geneticist is looking for and going to help parents talk about what's the risk of having other children with this, what's the chance of this child when they're older and have children that their children are going to have cleft lip or palate. And so just another person to just arm those parents with knowledge. And it's I think, very important to have that part of it too. We have a pediatrician who focuses on the craniofacial side of things, more just to kind of have the overview of are all the other needs of the child being met.
Sure.
We have a social worker, which is key, and she really helps with.
She's the MVP.
She is 100% the MVP.
She's the point, huh?
She's the one who basically says, here's all the resources that you need.
Yeah.
Where are we struggling? She does she acts as a psychologist as well, and can help getting counseling and getting things if we need that. But just she's really the person that ties it all together. Who am I leaving out?
The neurosurgeon. So
Yes.
sometimes we have children that it's not just the cleft lip and the cleft palate, but they have other craniofacial anomalies, such as craniosynostosis, the children that have fused, and that's Dr. Morris's specialty, where the skull bones will fuse and will make the head misshapen. And so we also hold a cleft team where we sort of sequester those patients to be seen so that we can also include neurosurgery and see those children in the team setting.
I think it's so incredible to hear about just the many hands that touch a certain case. Like, it's just incredible the amount of detail and care that your team puts into these patients. And I think that shows the connections that are made can really help put that child on a really healthy path in their life. Well, tell me a little bit about what are some tips for parents who may be facing a cleft lip or cleft palate? What are some tips for managing their baby's cleft lip or cleft palate, and how can they help them along?
So just like Dr. Morris just mentioned, we sit in the room with these moms and fathers and other family members who are pregnant with a cleft child, and it's just overwhelming.
Yeah.
And so that's why I think that prenatal visit is so important. And I do think that they need to hear that this is incredibly common, and that as soon as they have a child like this in their life, they're going to see it everywhere.
Yeah.
Okay? And then the other thing is just what Dr. Morris said. This child is going to be okay. They're going to come out knowing how to feed and how they want to feed, and they're going to figure it out. It's not actually, sometimes we have little hills to cross, but we can get them through it.
Yeah.
And the fact that the majority of these are isolated findings, we call it polygenic multifactorial, where the majority of them don't have syndromes or any other abnormalities.
Yeah.
They will be just as smart, fast, and awesome as every other kid. They're just going to have a scar.
Yeah.
Okay, so that's the first thing we tell them is when you get this diagnosis, don't panic.
Yeah.
And so we often can tell, and our nurses that take the phone calls, once we get the referrals, they actually know if they can hear it in the mom's voice.
I'm
So
sure.
Dr. Hetzler, Dr. Morris, we need to get them in quickly.
Yeah.
And we'll often do that. Sometimes we call them on the phone and just say, look, we're going to talk more formally tomorrow, but is there anything we can do to help you rest better at night tonight? And so when we speak with the parents, at the prenatal visit, we talk about all the little different things that they can do. Once the child is born, if we can go visit them, we will. If you are born within our system or in the group of people that we know, Women's Hospital is wonderful at taking care of our babies. But sometimes we have nurseries and other outlying areas, and they will call us and we'll just give them tips. Sometimes whenever the cleft lip is wide, even if there's not a cleft palate, because the cleft palate is what really makes feeding from a bottle difficult. So if a mom has a cleft lip and she wants to nurse and the palate is unaffected, we want that mom to try to nurse. It's the palate that causes the problem with the suction. Okay, it's imagine our speech therapist and our feeding specialist always talks about it's like trying to suck from a straw that has holes in it. You can't really get the fluid up, okay?
Yeah,
and so
makes sense.
without the palate, you can't create with the cleft in the palate, you can't create that suction. So they end up chomping on the bottle, and that's the mechanism by which specialty cleft feeding bottles work. It's a compression method, okay? So if you have an intact cleft palate and you're born with a cleft lip, you should try to nurse, and you should be able to. Sometimes the lip is wide and moms might have to put a little manual pressure with their fingers to kind of help those lips close. Sometimes we do a little piece of tape so mom doesn't have to use her hand, and tape it so that mom can get that baby can get the closure on the mom's breast and still nurse.
Yeah.
Now, once the child has a cleft palate, we know how hard that is for moms that are really dedicated to nursing. And so we tell them, if you want to try that bonding first, but with the cleft palate, you're never going to be able to empty the breast. So you're going to have to pump to maintain your blood supply, milk supply. And so once the baby is born, we start plugging them into the specialty feeders that we have, that compression method bottle, so that the babies can feed just from a specialty feeder. And we have great bottles now. If you go back 10 years, the bottles were really difficult to work. Sometimes you had to compress them for the baby. Really only mom and dad knew the rhythm of the child feeding. They were exhausted all the time because no one can feed them. Now we have great bottles. And so it's actually... the feeding and everything, you figure that out in the first week, and they should do really well.
Well, it sounds like no matter what these patients may face, there's resources and interventions and things to get them there. This is nothing that you don't hit a dead end in any capacity with this.
Never.
Well, speaking of interventions, when is surgery required? Where there might be a time where there might be a procedure, surgical or not, to correct any of the abnormalities?
So depending on what's affected is the key, right? And so probably the more common type of cleft lip and palate that you're going to have is what we call a complete cleft lip and palate, where it's the entire lip, the skin of the lip with the muscle, the gum line, and the palate. So it's one whole side completely open. And so for that, there are going to be multiple surgeries. We can't do it all at one time. Physically, you could potentially close it all at one time. The problem with that is it will cause problems with growth in the future. And so people have been doing this for decades and decades, and we've learned a lot. Basically, every decade, we kind of learn new parts of how do we make this better? How do we get better results in the long term? And so we've learned kind of the overall recommended time frames for each one of these surgeries to occur at different stages of growth. And so in the very beginning, we close the lip itself usually around 2 to 3 months. And so that's the first surgery, is around that 2 to 3 month time frame. We do the palate repair somewhere between around a year, sometimes a little bit early, 10 months, and up to about 1.5 years is kind of the ideal time to do that. And the key for that reason to be done around that time frame is because we want to have that palate repaired before they start speaking, because we want to have that palate put back together so that they have all the tools to have appropriate speech production. If we go late to that, then they're going to be behind the 8 ball. And so that's the goal, is to try to hit it around 1 year, no later than 1.5 years if we can. Then we let them grow, and all we do is focus on speech, speech, speech. That's Dr. Hetzler saying,
feed them,
speech,
we love
speech,
them,
speech.
and they grow, and then we just do speech, speech, speech.
Yes.
I love that.
To work on that palate, but they're still going to have a cleft of their gum line and right underneath their lip. And so that part doesn't get done until their teeth start to develop appropriately, and their adult teeth are getting ready to come in. So we actually get x-rays to follow and see at what stage are your specific teeth coming in. And we put a little bone graft where we take a little bit of bone out of their hip, we close the hole that's there that is going into the nose, and then we pack that area full of bone. So now we've recreated their gum line and the bone that holds the tooth, and then the tooth will actually erupt into that brand new bone, into its right little spot. Say right into its parking spot, pulls right in.
Magic.
Yeah.
Science.
And so there's some timing with that.
Incredible.
That is typically between 7 and 12. Is when that happens. Probably right around that 8-9 age is the typical, but somewhere between 7 and 12 around the country is the typical timing for that. And then after that, we just let them grow. Now, along the way, there's other things we're watching. Sometimes we'll repair the palate, but the palate might still be a little short or not be quite as strong and as functional as we need it to. So when they go to speak, they can have air that's leaking out of their nose, because the palate, its job is to push against the back of the throat and block the nose off at times, so that only certain sounds come out of our mouth, and other times it all comes out of our nose. I like to use banana as an example. Banana sounds kind of normal, right? If I squeeze my nose and I say banana, that doesn't sound right,
Yeah.
right? Or if I might say, hanana, it's all coming out of my nose. So you have to be able to close it and have a door basically that opens to let air out of your nose when it needs to be a nasal sound, and close when you need it to only come out of your mouth to be the oral sounds. And so for that, if it's not closing appropriately, or maybe it's a little too short, or other aspects where it's just not strong enough, we have to do a little surgery for speech to help make that speech better. That can happen as early as around 4 to 6 is kind of where we want to try to catch it, where their speech isn't coming out quite right. And not every kid needs that by any means, but that's what we're watching for. The other thing is we want to make sure that their upper jaw grows normally. So sometimes we do a lot of orthodontics to try to get that and make sure that jaw's growing normally. But sometimes we have to do what's called orthognathic surgery, which is jaw surgery, where we basically do a small surgery on the jaw where we break the bones and then pull it forward. A lot of people in the community will have that anyway for other reasons, but kids with cleft lip and palate are a little bit higher risk of having to need that surgery, but not always. It just depends on how they're growing. And then the very last surgery that we plan for, but it's really up to the child, in my opinion, and we kind of coach them through it, talk about all the reasons for this, and that is what's called a septorhinoplasty. So if you have a unilateral cleft, you will have a crooked septum. It's just how it forms and how it comes together. It just means you're never going to breathe quite as good out of one side of your nose as the other.
Okay.
And it also may have a little asymmetry to their nose because of how things were at the time of birth. And so for that reason, once they're done growing, once they've had all their surgeries to their jaw, because the nose sits on the jaw, we wait till all of that's done, and then the cherry on top, the icing on the cake, is to then say, do we need to do anything to the nose? And we'll do a septorhinoplasty.
So a lot of our kids it is not uncommon to have 10 surgeries if you're born with a cleft lip and a cleft palate, okay? And so some of our kids come to us and they say, oh, he's had 42 surgeries. They're probably counting maybe a little scar revision and ear tubes and things like that, but it is not uncommon for these children to have upwards of 10 surgeries between birth and about 18 to 20 years old, which the last thing we do being the rhinoplasty.
Well, and that's, again, going back to the team aspect of it, is for you to follow them through all of those surgeries. I mean, you're creating relationships and bonds with these families to carry them through what could be scary times.
We tell them we're going to be best friends before this is all over.
Well, is there anything else that you would want parents to know who either just are curious about this diagnosis or maybe facing it on their own?
Everything that we've said before, it is incredibly common. The majority of these children have no other abnormalities. They're just like every other child. Okay, so you're not going to have to typically not going to have to worry about developmental issues. They just have a scar, and then we'll work them through any problems that they have. Sometimes, even in the best of hands, super wide cleft palates, the palate heals short. If they have a speech problem, we handle it. And that's why it's the team approach. Whenever we meet them prenatally, we try to get them into the cleft team to meet everyone before we even do the lip. So we do that lip at 3 months. So they're born. We know they're born. We get them into the clinic sometime in that first 3 months of life to meet the team. It's a long day, and it takes a lot. We call it one-stop shopping. So the parents come, and the patient is put in a room. We tell them, bring your chargers, bring snacks, bring everything that you need to stay with us for a couple of hours. Because once they're there, it's one-stop shopping. We rotate through. And then after the patients go home, it's not done there. We go sit down in a conference room. We throw up their pictures. We throw up their x-rays. We throw up their hearing tests. We look at everything about them, and we come up with an individualized plan for that child. So you're never alone. That's why they leave with our cell phones. That's why we have a nurse coordinator. That's why we have social workers and all of those things. And we have a number of other allied health individuals, psychosocial, developmental, pediatricians, and everything that we refer our patients to because they might be needed. And that's why the team is there, for us to put our heads together and come up with the best plan for them.
Well, that speaks so much to the power of belonging to such a coordinated system of care, because you can lean on each other to provide the best support for your patients. That's awesome.
When I started this team in 2012, 2013, 2014, I would just call random people and just say, I feel like there's a hole in this community for this care. And there were people that were interested and there were people that weren't interested. Some of the people on our team called me and said, hey, I really want to be a part of this. And our team pretty much volunteers. Our dentists and our orthodontists make a lot of money in their practices. They leave their practices and lose money to just come and volunteer with our team. They don't bill, and they actually ask to be a part of it. And as we grew, whenever I first started the team, it was about one clinic every 10 weeks. So I saw 5 kids every 10 weeks, so 5 teams a year. And then now we are up to a clinic we see 10 babies every other Thursday. And we could see a clinic every week and we couldn't cover all of our kids. And so that's how much we've grown. And so it stressed out our dentists and our orthodontists because then they had to take more time away. So then we've recruited. They actually joke that I'm really good at getting people to work for free. That's because I am a state employee with LSU. We were able to recruit 12 pediatric dentists from the community who were already taking care of our babies anyway. And so now they rotate through, and we have probably 5 or 8 or 9 orthodontists that will, but it is a loss for them. But they really, some of them reached out and said, we want to be a part of this. And this is what, every time I apologize for it, or when I went to having clinic every other Thursday, some of them were like, well, this is what we should do, And so I think that's the meaningful thing. And I will tell you, parents that have been on other teams that come to our team feel that. They feel that positive. They feel that we're approachable. We're not just talking to them about their child. They feel like they can ask us questions. They learn something every time, and they feel like it is truly a positive, kind environment for them to take care of their child.
That's so powerful. I love that. Well, it seems like you both are so passionate about this work. What brought you to this very specialized field, and how has it been building this team and building this specialty out?
So I'll start on my first part and then how we were able to get Dr. Morris to join us here. So I trained in Chicago for ENT, otolaryngology. And then my second board certification is in facial plastics. So I went to California. So I was a part of teams in Chicago and California. Those teams were different. Not as big as our team. We talked about all the people involved. The American Cleft Palate Association is the ACPA. It is our designated body. It sort of accredits a cleft team, and according to them, you really only need a speech therapist, an orthodontist, and a surgeon to have a team. So I've been a part of those little micro teams that I call them, and in California, where I did my facial plastics and all my cleft work, we had a team just like we have here at Our Lady of the Lake, where it's fairly complete. We almost don't have to refer anybody out. We have everybody there for the patient and the family to meet at that time. And so we were ACPA accredited a year or 2 after we began running the team. I did it early. Because I felt that it was meaningful. I had to do it the next year. So we did it in 2015. I reaccredited in 2016, and then we just reaccredited again. Awesome. And it's actually an exhaustive process. You have to send patient records and show that you have all the people that are required for this multidisciplinary comprehensive care of this type of a child. So I was in California, and I'm from Louisiana. I grew up in Opelousas, and the chairman of our department at LSU was one of my first and favorite mentors. So as soon as I matched my fellowship, he said, you should come back here. And so I came back here. This was kind of one of my goals. I saw it as a deficit in the community, that we weren't, the later care of these children, the speech surgeries and the speech evaluations and the bone grafting and those things that come later weren't really being addressed. So we built the team. And I am faculty at LSU. This is something that's how Dr. Morris and I met. We go to national meetings. We teach courses on clefts. We publish on clefts. We have academic expectations from our institution, and it's something that's our expectation. We go to national meetings. We learn all the time. We never stop learning. And the most beautiful thing about our team, which I've seen nowhere else where I've been, is that people really want to be a part of it. So there were people that I called and said, hey, you don't know me. Dr. Superno, our geneticist, he's so wonderful. We call him Superno. We threatened to bring him a cape to every Cleft team. And so I called him. I said, you don't know me, but this is what I want to do. And he said, I'm with you. And so I called a number of people, but the most beautiful thing is that once we started gaining traction, people called me and said, hey, I want to be a part of this. So our amazing pediatric dentists, which there are 12 in our community, that volunteer their time. We probably have almost 10 orthodontists that volunteer their time. Those early orthodontists called and said, we actually really want to be a part of this. How can we help? And they volunteer at every single team. They leave their practices to be a part of this. And I think it's palpable. I think our patients that come to our Cleft team that have been other places feel how connected we are and how open we are to their questions and to educating them, and just that it's a positive and kind environment.
That's so amazing. I mean, the passion of the whole team speaks volumes, for sure.
Thank you.
What about you, Dr. Morgan?
Wow. So I'm originally from the Midwest. Kansas City is where I call home. It's been a while since I've been there. But and then I did my training for my otolaryngology training was in Portland, Oregon. And it was in medical school in Kansas where I first started to interact with a lot of the facial plastics aspect of just patient care in general, but that's where I kind of got introduced to cleft lip and palate. I didn't know that much about it. I worked with people who went on a lot of different missions and said, oh my gosh, I'm really interested. Tell me more about this. And when I went to Portland, they also had a heavy mission focus for treating children with cleft lip and palate, and was able to do a lot more hands-on work with them and got to start going on missions with them as well. And it's one of these things, just the excitement, the positivity, it's making and changing and actually literally creating smiles, right? Like you're changing everything and just bringing so much hope and excitement to this, to people who are worried that this is going to have a long-term impact. And you're like, really, no, this doesn't need to. We can fix this. We can make it better. You got this, right? And it's such an inspiring, exciting place to work and saying like, I can do this for my life. Are you kidding me? Right? Of course. Yes, sign me up. And so after I did my first training, I went on to a fellowship focusing on cleft lip and palate and also craniofacial surgery as well. In New York. And so I did my fellowship in New York. And after that, did yet one more fellowship in craniofacial surgery in Salt Lake City. And so I've kind of been on different teams a little all over the country. I've now trained in all the time zones, basically learning how they do cleft lip and palate all over the country a little bit. Of course, right here. So it's been something that it's just once you get a little bit of that, you become a part of it. It like envelops you, right? It becomes who you are almost. I mean, I consider all my patients family. I'm going to know them for the next 20 years, right? I know their families. I know their struggles throughout life. We remember back when we were 4, now we're 12. And it's such a rewarding thing to do. And I love every aspect of it. So that's what got me into it. And then when you see all the possibilities, you're saying, man, we can take this so many places and reach so many people. And I'm going to digress just briefly because you had mentioned before, what do we wish parents knew that had clefts? And I will say that sometimes we just talked about how this is a really long journey. It's all the way through till adulthood and even sometimes past and into adulthood. That sometimes that can become disjointed along the way. People move. I've lived now in many states, right? And so people are going to move to different states, different teams, and maybe they were never part of a team. And so they made it to a certain stage and they just said, okay, I thought I was done. I didn't need anything more done. The reality is there's a possibility there are multiple things that could still be offered if we needed it. And so I think it's always exciting to find someone who's kind of, I wouldn't say astray, but has kind of been a little bit lost. And then they're like, oh, wait a minute, there's more there, and I still have some issues that I would like to address. And so then we can address it. I've done septorhinoplasties on adults in their 50s and 60s that said, gosh, I'd love to breathe better through my nose. And I had no idea. I thought I could only do that when I was a child. You can do it anytime throughout to keep addressing anything that needs to be addressed. So I think that's the other aspect is if there's any concerns or issues, reach out. That's the whole point. There's always answers. There's always options to keep getting where parents and kids want to be.
That's amazing. Well, you both mentioned speaking at conferences and publishing and research and being a part of LSU faculty, and academic medicine can sound kind of big and scary. And but can you tell us a little bit about what that means and what the power of that brings to a system like ours, where you really can, like you were saying, create some pretty cool things?
I think one of the beauties of academic medicine is just lifelong learning.
Yeah.
And then always, and I actually run the residency for otolaryngology head and neck surgery. So I have 20 residents that I'm responsible for. And my expectation, and they all have a research rotation, is that they learn to ask a scientific question. And so all of us in academia are always asking that question, how can we be better? How can we be better? And so we train our young learners and our young surgeons that way, and it's just a part of our life. When you choose academia, you choose, sometimes it's because you're doing bigger things that really don't fit in a smaller setting. You need, some of the surgeries I do require multiple other surgeons to be a part of it. And so I think that academia is something that is just a fertile ground for how do we make ourselves better? How can we do better? And we ask ourselves that question all the time. Dr. Morris and I actually, as soon as she started here, I said, I want to operate with you. I want to see how it is that you do. We're both trained differently. There's a myriad, you could, pages and pages of the different type of cleft lip repairs. My cleft lip repair is kind of a blend of the parts I like of 3 specific cleft lip repairs. She does a little bit of a different way, but I learn something from her every time. In Utah, where she practiced for a while, they had a very unique way to address cleft palates. And so I think that bringing her knowledge, adding it with my knowledge, I think that more brains are always better than one. It's that whole team model.
That's great.
I think it encourages, this is kind of what you're getting at, but it encourages collaboration.
Yeah.
And when you're in private practice, it's a little bit harder because you have to make your ends meet, right? It's a little bit of making sure you're taking good care of patients, but it's not so much of having time to say, I'm going to go work with this other person or another person. And it's kind of part of and expected within the academic practice, at least from my personal experience. And so I think that's where, we can have, I have lots of cases where I'll have an orthodontist or a dentist with me, even in surgery, going in and addressing patients like for the actual surgical procedure, as well as Dr. Hetzler, as well as our neurosurgeon. We'll have lots of things where we can just collaborate, and it's expected, and it happens easily, especially within a children's system where we're in a children's hospital where everything's available. And so you can really just reach out to each other, and that's just the norm. And so I think that's really, it opens a lot of more doors. And especially, we briefly talked about our social worker before. That is something that having a social worker, being part of an institution that can support the bigger model of how do we care for kids, how do we be all inclusive, how do we give comprehensive care, not just I'll fix your lip, follow up with you later, right? It's how do we take care of you? How do we take care of your family? How do we take care of you as an entire whole? And I think that both being academic and within institutions that focus on that is the key.
Well, this has been so informative, so interesting. I can just tell the passion you both have for these kids, and I just know that the families benefit so much from the team. And so thank you for sharing with us today and for being here.
Thank you.
We're super excited to be here, so thank you.
And thank you for being here. I hope you found this as helpful and informative as I did. We'll see you next time on another episode of ParentingU, where we are with you every step of the way on this amazing journey we call parenting. See you soon.